you everyone for joining us. I'll have Dr. Brandis introduce our guest today, but just so everyone knows, we will have, it's a unique kind of day. We'll have a lecture by Dr. Terris and then a case discussion at the end followed by another lecture at the 8 o'clock hour. But here, Dr. Brandis, if you don't mind introducing our guests, then we can go from there.
Yeah, it's my pleasure to introduce Dr. Martha Terris, who's the chairman of the Department of Urology at the Medical College of Georgia. She did her urology residency at Stanford and fellowship at Stanford. And then I met Martha actually 20 years ago, or almost 20 years ago, at Stanford while she was on faculty there. And she's been the chairman at the Medical College of Georgia now almost 15, 20 years, or more than 20 years.
I've been here for a little over 20 years, but chair for 8.
8, I see. All right, well, thank you so much for doing this. When this coronavirus epidemic passes, we'll have to bring you here in person when it all is safe. So thank you so much for doing this. Thank you.
Yeah, thank you for the invitation.
Yeah, thank you, Dr. Terris. So as Dr. Brandis mentioned, one thing that, because we have so many residents listening, we'd love to hear your kind of just a little bit of background as to what brought you to this point. And then also, I wanted to kind of gauge your opinion on the current environment that medical students are dealing with regards to applying into urology. See what you thought about the virtual sub-I experience, what you thought about capping applications for urology applicants, and overall, what do you think we should do with the match? So if you don't mind, just giving just us a little taste of kind of what brought you here, and then anything that you advice you can give for the medical students who also are popping in and listening would be great.
Sure. Thanks so much. So career path wise, you have to make a decision, and most of us make this decision fairly early in residency where we're going to do an academic path or not. The question is, what do you do with that? Do you want to be, the productive researcher? Do you want to be the great teacher in the OR? Do you want a leadership position? Mm-hmm. And you really have to decide. You can't be great at all of those, or you can, but you have to have one as a priority. And I was on the faculty at Stanford, which is an amazing institution, great resources, beautiful part of the country. And if you look at my CV, you say, why in the heck did she go from Stanford to Medical College of Georgia? And, at Stanford, there's a Nobel laureate on every corner, right? So it's very hard to make your name at an institution like that. Whereas it's the little fish, big C, big fish, little c sort of question. So that's one that I think junior faculty members or residents sort of thinking where they're going to go for an academic position ultimately should consider. I mean, what are the options for upward mobility if you want a leadership position? Sure. And I think that's one of the things that got me where I am today.
Sure.
What was your other question?
So
for med students at this match, yeah.
So I guess kind of your opinion on what, with the current environment of canceling sub-internships, what kind of advice do you have for medical students? What do you think the cap should be on applications? How do you feel about the virtual sub-I as an option?
Yeah, well, the virtual sub-I is going to be better than no sub-I, right? So we're all working on taking videos of our conferences and things like that, just like you're doing right now, to get our program's name out there, have something that students can see, the good things about our program that they are not going to get to see because they didn't do a visiting rotation or even an in-person interview. I mean, you can't tell that Augusta is a great town and all the residents own their own homes. because it's cheap to live here, and you park once and you can get to all the hospitals. They're all connected. You know, there's those physical things that you get out of the visiting rotations and the interviews are going to be missing. And so it's up to us programs to inform the students. So that's on us as programs, not on the students.
Right.
And I understand that the ACGME is going to put out a position statement here in a couple of weeks, informing us all of what their take is as far as allowing visiting rotations and allowing in-person interviews. So we're going to have some marching orders come out soon, and then we'll know how to cope with those.
Gotcha.
As far as medical students are concerned, I'm not in favor of a cap. That's an unpopular opinion, because I'm at a small program. And in the South, we have a lot of medical schools that don't have urology programs. And I don't know how those students are going to be able to, they're not going to have good advice, especially without a visiting rotation, on where to apply, you know, what is their range of programs as far as competitiveness that they should apply to. And you've got the folks that maybe didn't match last year, or people that are foreign medical grads. You know, I think those people will be hurt by a cap. I think your standard allopathic senior US medical student, you could cap. You know, if you had a good advisor, there was a good urology program at their school, then they could be advised, and there could be a cap then. But if you apply it to them and not the rest of the people, it's unfair. So I don't know what the answer is. I'm not a huge fan of caps, but I think we should just drop the price. Everybody says, oh, it's so expensive, but just drop the price of applying to more schools. And then anyway, that's my opinion. It's not a popular one though.
No, I hear you. It's very difficult. I think I come from one of those programs where we didn't have a urology department, and you kind of have to make a name for yourself. And in that same vein, you have to apply to a lot of programs. But it's kind of difficult now where you have this situation where we're not allowed to showcase ourselves with sub-Is, and then you want to also cap. So it's going to be very difficult. In terms of the match, though, do you feel any one way or another about moving the match itself?
I think this year it will be moved forward a bit, just because things are going to be running behind. The step tests were postponed too, and you know, I think we will be anywhere from 2 to 6 weeks later in the year next year getting the match done, but that's just a guess. The SAU will meet immediately after the ACGME releases those, the Society of Academic Urologists who run the match with the AUA. They will meet immediately after the ACGME releases their verdict on what's going to happen and come up with a plan for the urology match. So we should know what the official plan is here in another 2 or 3 weeks.
Gotcha. Okay. Well, thank you for all of that. With that said, please, everyone, thank you for joining us. I'll kind of give it to you, Dr. Terris, and once you're over, we'll kind of transition to the case. And if anyone has any questions, please feel free to place them. This will be a very interactive. Just put them in the chat, and we'll go over them with Dr. Terris. So thank you again for being with us.
Sure. Can you see my screen?
Yep.
Okay, great. All right, let's get started. I'm going to talk to you about salvage lymph node dissection for recurrent prostate cancer. I'm going to start out with a case. This is a patient of mine. He presented to me as a healthy 63-year-old. He had had a prostate cancer on biopsy for a PSA of 4.3, showing Gleason 4+4 in 7 of 15 cores in 2008. He was treated with androgen deprivation therapy for a short period of time and brachytherapy at that time. This was all outside. His PSA natered at undetectable levels and was undetectable in 2014 when his PSA was found to be 0.2. It continued to slowly rise, 4.87, and then a month later, 6.37. Pretty unremarkable history, hypertension, hyperlipidemia. Imaging showed his brachytherapy seeds and a single enlarged lymph node at the right external iliac fossa. This is a CT scan showing this enlarged node. You can see there's a pretty big one. This is just another view of the CT. He underwent repeat transrectal ultrasound guided prostate biopsies, and they were all benign and showing treatment effect. He underwent a flucyclovine or AXUMIN PET scan that showed intensely increased activity in the area of this enlarged nodes and no increased activity in the prostate and no other signs of lymphadenopathy. Here's an image. You can see the bladder lighting up down in the inferior portion of the image, and then that very hot lymph node on the right. Here's the axial scan showing that very hot lymph node exactly in the spot of that enlarged node on the regular CT scan. He was advised by his outside urologist that ADT was his next step, but he was opposed to hormone therapy. When he had it when he was 54 with his brachytherapy, he was really miserable. So he came to us for a second opinion. We know that the biochemical recurrence rate, especially with this young African-American man with grade 4+4 cancer in half of his biopsies, is going to have a high risk of recurrence. His options are androgen deprivation therapy, which is the standard, but we know that has some undesirable side effects, especially in young men, will progress to castration-resistant disease, and significant cardiac toxicity in the long-term, cardiovascular disease in this guy that's already got some hypertension and hyperlipidemia. You can do intermittent therapy to minimize the symptoms, which is a nice option in some of these fellows. There's salvage radiation therapy, salvage ablation, such as cryotherapy. But what we're going to talk about today is the salvage lymph node dissection option. Lymph node metastases have a more favorable outcome than mets to other organs or to bone. In long-term follow-up study, there's good cancer-specific survival in patients that had limited node-positive disease after prostatectomy, even without hormone therapy. And removal of the nodes may have a beneficial impact on cancer progression, and it can at least delay the need for androgen deprivation therapy. This is a nice diagram of where nodes tend to be shown on imaging studies after radical prostatectomy. And there have been several articles in the literature, in the radiology literature, telling where these nodes are distributed. But this is a nice diagram from the Rigotti paper that's almost 10 years old, and the rates of those nodes are pretty much the same, even in the most recent publications. The vast majority of nodes are in the pelvis. Now, worrisome number are up higher in the retroperitoneum. Salvage lymph node dissection after primary therapy has been purported to prolong recurrence-free survival and delay systemic therapy. But to be able to pull that off, you need imaging, very efficient imaging, to identify these nodes, to even know what to take out. And we know traditional CT and MRI have low sensitivity. So let's talk about imaging for a little bit. PET-CT has been a tremendous benefit to us in cancer imaging. The old standard is FDG PET, which we use for a lot of our imaging in urology for metastases. Other options are the F18 fluoroethylcholine, 11-carbon acetate, 11-carbon choline. Then the last two are the ones, the last three really are the ones that are used a lot in this recurrent prostate cancer space. The 11-carbon choline, the 18 fluoroflucyclovine or AXUMIN, and the 68 gallium PSMA, or the prostate specific membrane antigen. The AXUMIN scan, it's our favorite here. It was developed right down the road at Emory from us, so it's one we've had available for longer. Sensitivity of 58%, specificity for 81%. It's easy to handle. It has a fairly prolonged T1/2 before the isotope starts breaking down, so you scheduling and things like that is a lot easier with it. The prostate specific membrane antigen isotope is probably more accurate, 55% detection with very low PSAs and up to 76% detection in PSAs of 0.5 to 1, and can detect fairly small nodes. The limitations, however, it's got a short half-life. You really have to take it right from the cyclotron where it was created to the patient with a 20-minute half-life. So you have to have an on-site cyclotron, which not a lot of sites have that. An international study of recurrent prostate cancer patients that just recently came out compared the 11 choline to the PSMA and 641. And basically all of the patients, these patients ultimately went on to have a salvage node dissection, and they compared those results to those two imaging techniques and found that across the board, the PET-CT scans underestimated the burden of nodal disease. The PSMA study was associated with a lower rate of underestimated in the low PSA range, less than 1.5, but in the higher ranges, there was no benefit of the PSMA over the choline imaging. Another potential option is diffusion weighted MRI with ultra small particles of iron oxide. These have a high sensitivity, are easy to see on MRI, but are really not very useful in the salvage situation since you have to inject the primary lesion to get uptake. Similarly, there's several technetium labeled colloids that you can inject right into the prostate and then see where it goes in the nodes, as well as a hybrid of ICG, that's indocyanide green. Some of y'all may be familiar with that. We already use it in urology. Some people use it for partial nephrectomies during a robotic partial nephrectomy to determine the edge of the cancer versus the edge of the normal kidney using the fluoro option on the robot. So that's something that we have used. And so there's a hybrid of ICG and technetium nanocolloid that you can view intraoperatively, but all of those require injection to the primary tumor. Here's an example of intraoperative intraprostatic injection that shows up on robotically with the green in the fluoro. But a very nice paper a few years ago from Penn showed that you could actually give it in the salvage situation a day prior to the node dissection and still get uptake in metastatic nodes. And that's the image I've shown you here from that paper. And of course, I know you're all sitting there saying, well, that giant node, I wouldn't need it to be bright green to be able to dissect that out. But I think it would be helpful for more subtle nodes. This is another technique. This is people with nodal disease after radical prostatectomy that had uptake on PSMA PET. And they had an IV injection about 48 hours prior to salvage node dissection of indium labeled PSMA. They underwent a repeat scan about 24 hours prior to lymph node dissection to be sure there was uptake in the lymph nodes, and then underwent lymph node dissection. And they had a gamma probe intraoperatively to measure the isotope and guide their dissection. Even with all that, the sensitivity and specificities weren't amazing. There was still a fair number of tumors that were missed and a fair number that were positive, that were detected and called positive on the imaging that were negative. So a lot of problems with that. Future imaging with prostate-specific fluorescent compounds are being developed, such as this Y27, which is a near-infrared fluorophore targeted to PSMA, and antibodies against prostate stem cell antigen that fluoresce. So we'll see if new things come out with time. Salvage node dissection should be considered a fairly experimental treatment option for prostate cancer with nodal recurrence. After primary treatment failure, there's a lack of current guidelines The main aims of the procedure is to delay further cancer recurrence and postpone use of systematic treatments. And that's very important when you're counseling patients that might be a candidate for this, that have this single node that takes up the isotope on your PET scan of whatever type you're using, that all we're doing probably is delaying their hormone therapy. We're not going for a cure here, and they must understand that, because even though some of the authors that are publishing about this say that there is a chance you can cure it, I certainly wouldn't make any promises to a patient. There's a nice review article in European Urology from about 5 years ago, looking at all of the studies that have published on salvage lymph node dissection. Most of them are very small series. There's a few larger ones there. And the more recent ones have gotten more and more careful about their patient selection too. Overall, 40 to 80% of patients achieved a complete biochemical response of a salvage lymph node dissection, and that would be defined as a PSA less than 2. Reaching a complete biochemical response was a significant predictor of whether their cancer would progress later. Preoperative, and I mean pre-salvage lymph node dissection, preoperative predictors of a favorable biochemical response after the salvage lymph node dissection, or a PSA less than 4, a greater time from the radical prostatectomy to the biochemical recurrence, node negative at the time of the prostatectomy, no retroperitoneal uptake on the PET-CT, and no more than 1 to 3 areas of nodal uptake. Most patients invariably progress to biochemical recurrence despite an initial biochemical response. The median time is about 18 months. Depending on the author, there's a 9 to 31% biochemical recurrence-free survival at 5 years. One group has 3 of 13 patients with complete remission at 7 years and talk about a cure. I'm not sure that's possible, but it's interesting. So a clinical recurrence, not just a PSA recurrence, is a positive PET after lymph node dissection, and with a rising PSA. And there's a 35 to 50% clinical recurrence-free survival at 5 years. Postoperative predictors, postoperative meaning after salvage lymph node dissection, predictors of clinical recurrence are pathologic nodes in the retroperitoneum, a higher number of positive nodes, or incomplete PSA response to salvage lymph node dissection. Complications, it's not completely benign. There's been no mortalities reported. The patients have fever, lymphorrhea, DVT, basically anything you would think would be a risk of your lymph node dissection that you performed at the time of your prostatectomy, lymphocele wound infection, and required surgical intervention. And several people have also published this list of complications, and it's fairly consistent among the publications. There's been a nice pooled data of 654 men that underwent salvage lymph node dissection. Now, many of these were also among the 200 or so that were in that review in 2015. So some of it is carryover, but this does include some US sites and some other very experienced salvage lymph node dissection surgeons. This publication said that 25% had within 1 year a PSA recurrence. Early recurrence was significantly associated with an increased risk of 3-year cancer-specific mortality, with 20% cancer-specific mortality in those with early recurrence and 1.4% in those that didn't have a recurrence. So for salvage lymph node dissection, your ideal patient is a young, healthy patient with prostatectomy path stage of T2, Gleason score less than 7, PSA less than 4, castrate-sensitive disease. I don't know how you do that if you haven't given them hormones already, but that's one of the listed recommendations. A low lymph node burden, Various authors give various recommendations, but they pretty much agree less than 3 sites. It must be limited to the pelvis. Your PSA shouldn't be contaminated by having already given hormone therapy, and a longer time between the radical prostatectomy and the detectable PSA. What about our patient? He had brachytherapy. So he doesn't really fit into any of these categories, but he's young. His path was T2. His Gleason score was a little high, and his PSA is now 6.5. He's only got 1 site. And it's been 9 years since he had his brachytherapy. So we gave it a try. Again, this is his PET scan, his AXUMIN scan, showing you where that node is. Here's a robotic view. You can see nice, friendly pelvis there. You can see the arrow is pointing out that node that's bulging. As we're dissecting it out here, there it is, really obvious node. It wasn't that subtle. Final path was metastatic prostate cancer involving 1 of 10 lymph nodes. So that big honking node was the only one he had. We also dissected the nodes on the other side. We didn't get a very extensive dissection, but of the 5 nodes we got, none had cancer in them. And this is what happened with him. His PSA initially pre-op went from 6.3 over the next 9 months down to 0.02. Stayed there for a little while, but at 18 months, it popped back up to 0.3. And again, that was the mean recurrence time in the previously published studies as well. So he's following that trend exactly. At 2 years, his PSA was up to 2.23. Imaging at this point is negative, but we went ahead and started androgen deprivation therapy and abiraterone. And that was just 3 months ago. He's just recently started that treatment. So did we do the wrong thing? What are the other options? Our options include observation. Maybe we could have just watched him longer. His PSA was 6.5 and he had a big node. That would be pretty risky, but looking at the STOMP trial, you may have heard of this trial, 62 patients were randomized to observation or treatment of the MET. So unfortunately, only 6 of those got salvage lymph node dissection. 25 got radiation therapy to the metastatic sites. And they were followed for a median of 3 years. The median time to PSA progression was 6 months for the surveillance group compared to 10 months for the patients who underwent treatment of their metastases. ADT was started for radiographic progression or worsening symptoms. The ADT-free survival was longer after the metastatic disease had been treated, a mean of 21 months, compared to 13 months in their surveillance group. What about going ahead and doing ADT? Should we have not even bothered with a salvage lymph node dissection and just gone straight to ADT, as his outside urologist had mentioned? There is one study that compared salvage lymph node dissection directly with ADT. There were 23 patients who underwent node dissection and 22 who had ADT for lymph node only recurrence after prostatectomy. The mean PSA reduction was higher after salvage lymph node dissection than ADT. The clinical groups were not significant. The clinical outcomes were not significantly different between the 2 groups, but there was a trend toward longer time to biochemical recurrence, 13.3 versus 6 months in the salvage node dissection. The salvage node dissection group had 13.3 months and the ADT group had 6 months. And radiographic evidence with 21.1 months for the salvage lymph node dissection group and 14.2 months for the ADT group. These differences didn't meet statistical significance, but are certainly important trends to know. Then if we compare, there has been one direct comparison of salvage node dissection to salvage node radiation. This was not a very good study, but it's the only head-to-head comparison out there. They had 67 patients who underwent radiation therapy to the nodes and 33 that underwent salvage lymph node dissection for pelvic or periaortic lymph node recurrences after radical prostatectomy. The RT group had higher stage and margin rates at radical prostatectomy and higher PSAs at the time of salvage treatment. The lymph node group had higher rates of PSA persistence after radical prostatectomy. The distribution and number of lymph nodes on imaging was the same for both groups. 88% of the RT group started ADT, and that's why I don't think this is a good study, because sort of your PSA data goes out the window then, with 25% of those continuing it for 2 years. And 54% received additional radiation therapy to the prostate fossa. So we're really comparing apples and oranges here a bit. But the 2-year biochemical recurrence-free survival was significantly higher in the RT group than the with lower rates of starting ADT. But of course, they had a lot of patients that were actually on ADT already. And but so I don't know that we can make any big conclusions about the biochemical recurrence rate or the starting to ADT. However, the RT group did have lower rates of distant metastases. So that is a bit concerning and may actually suggest that RT to those nodes is more beneficial to the surgery. But again, there were a lot of issues with this paper. I'm not sure I'm ready to believe that yet. In conclusion, salvage node dissection is a viable treatment option to delay clinical progression and postpone hormone therapy in those patients with a low node burden that really want to avoid starting hormone therapy. Patient selection criteria are still a little up in the air, but I think we've got a much better idea based on some of the literature. Imaging techniques tend to be the crux of the matter. If you know what nodes to take out, you've got a better chance, or if you know how extensive the disease is, and if the patient's a true candidate for salvage node dissection, your success is going to be better. And of course, there's a possible role for a multimodal approach, and that hasn't been looked at, but I think that's probably where we're going in the future. Thank you.
Great, thank you so much, Dr. Terris. That was a great review of kind of previous and up-to-date literature on salvage lymph node dissection. There was one comment during the talk. It was by one of our medical oncologists, Dr. Chuck Drake, who was just mentioning that for the PYL, PSMA, PET. Oh, Dr. Drake, are you here?
Yeah, I'm on actually.
Oh, awesome.
I can talk if you want. I mean, that was a great talk actually, and I think that you know, the idea of doing a salvage dissection is certainly probably very reasonable in some cases. And I think that the imaging technology that will be FDA approved by the end of the year is not gallium-68. I doubt it actually. Gallium-68 is Betty Crocker. It's actually when you like make the isotope yourself in the back room and then you take it in and image it. And there's variability as the data you showed actually. The agent that'll be approved probably is PYL PET. It's actually a more stable reagent. It comes from a company called Progenics. We're doing a trial here at Columbia. We've already imaged more than 80 patients. In studies of this agent at other places, including Hopkins, they showed us specificity and sensitivity much, much higher than you showed for gallium-68. That is, in one study, there was for PSA greater than 1 or 2, the specificity was greater than 90, sometimes even 95%. So I think that what you showed is exactly super important, right? Because what's going to happen is if that technology gets approved, and we think it will be, what will happen is people who have rising PSAs, like you showed, are going to get imaged, right? And you see juicy lymph nodes often, because that's where prostate cancer goes. And then this question is going to come up actually. So I was wondering if you have any experience with that other imaging technology with PYL or any availability in your area.
No, we don't. Like I said, you know, we're mostly doing AXUMIN now because it was, you know, developed by our neighbors over at Emory, and it's so easy to handle. But that's a great one that we'll certainly look into when that gets FDA approved.
Another question, Dr. Terris, we had are related to the criteria of starting hormone therapy for those who have nodal disease, but those that you're not going to do a salvage lymph node dissection on.
Yeah, that's a good one, you know, and that's what the STOMP trial was all about, right? Was do you even need to do anything for these? Can you just watch them. And the criteria there for starting hormone therapy in patients that had been randomized to the observation arm was progression of disease radiographically or symptoms. They didn't use PSA alone as a indicator to start ADT. And I think that's reasonable when you've got just nodal disease.
Right. And then in those who have clinically nodal disease prior to any intervention, and given the benefits of salvage pelvic lymph node dissections, what are your thoughts about prostatectomy plus pelvic lymph nodes as an initial therapy option?
Yeah, I think we're going more and more that direction. I'm not a big believer in it. I think those people also are going to fail and end up on hormone therapy or ultimately, if it's very bulky. I do think when you have this incidental focus of cancer in a lymph node dissection that you do at the time of prostatectomy, you've probably done those people a favor. But if it's bulky enough that you could detect it on preoperative imaging, I'm not sure about that as far as disease control, but you may postpone hormone therapy. Then the next question is, what about their local disease? And we know that you do save some of these young patients with bad local disease. You save them from getting into trouble with urinary retention and other problems down the road by going ahead with prostatectomy, but you may end up with incontinence and some other problems that they may find undesirable. So it's hard. You've got to really spend time advising those patients. I think it's not an easy across the board answer for that one.
Sure. Oh, that makes sense. So it seems like that as far as questions, that we don't have any more right now, but I want to get the case uploaded for you. So I'm just going to start sharing my screen, and then we have one of the pathologists here from Columbia, as well as a radiologist, who will go through the case with everyone. So give me 1 second. Let's see if I can. Okay. So Dr. Terris, this is a patient that we wanted to go over with you. It's a 62-year-old male, history of ulcerative colitis, had a subtotal colectomy and a J pouch over 30 years ago. At that time was complicated by a bladder and prostatic injury, subsequently developed a recto-prostatic fistula. He had attempted repair, a transperineal fistula repair in 1990, which failed. He noted recurrence of fecal urea and pneumaturia beginning in 1998 and really lived with that for many, many years. Then in early 2019, he underwent a cystolithopaxy. He also had a prostatic stone that was treated. This was complicated by postoperative retention. He failed multiple trial avoids, and ultimately suprapubic tube was placed for him. But during that cystoscopic and radiographic workup, he had what appeared to be one, if not two, fistula arising from like the right side of the prostatic urethra at the level of the veru. And he did undergo a green light laser vaporization of the prostate for obstructing prostate, and simultaneously a pouchoscopy at that time, which is notable for a very narrow ileal pouch anal anastomosis from his previous surgery. So he was advised to have a fecal diversion prior to repair of the newly found fistula, but he refused. Ultimately, in November of last year, he underwent repair of a rectourethral fistula, a urethroplasty. He had a gracilis interposition flap, had some of his prostate removed, and a rectal stricturoplasty. Ultimately, his post-op was complicated by a rectal leak, sepsis. He had to undergo an emergent washout and loop ileostomy creation. Post-operatively, he had a cysto as well as a gastrograph and enema in February that showed no obvious leak or stricture. But about 2 weeks ago, he started noticing recurrence of pneumaturia. He's having foul-smelling mucus per rectum. Just of note, his pathology of that prostatic tissue in November was consistent with basaloid features, carcinoma with basaloid features. So, Dr. Verk, are you with us right now?
Yes, I am here. Good morning, everyone.
Good morning. I'd just like to introduce Dr. Verk. She's one of our assistant professors of pathology here at Columbia, and she's going to be going over the pathology with us, Dr. Terris, with regards to this prostate specimen that was removed during the operation.
Hi. So in pathology lab, we received 2 pieces, 2 centimeter and 1.5 centimeter of prostate tissue. And both tissue were occupied by this tumor. And as you see on the left, in the left image, prostate urethral lining is on the surface. This is the low power magnification of the tumor to show the extent of the tumor. And you see that little bit of the space below the epithelium is uninvolved. Rest of the space or prostatic tissue is occupied by the tumor. And on the right side, you can see the blue color on the image that shows the deepest part of the tissue. And as you can see, the tumor is occupying the whole depth of the tissue submitted to us. I would say more than 90% of tissue submitted to the lab was involved by this tumor. Next slide, please. Now, this is the medium power magnification of this tumor to show the growth patterns of tumor. On the left side image, it shows a big a nodule of the tumor with spaces in between the tumor proliferation, and there is palisading of nuclei towards the periphery of this large nest. Now, this is called cribriform growth pattern. And as you can see, the stroma in between these group of blue cells, the stroma is pale. This is not the normal stroma for prostate tissue. Prostate has fibromuscular stroma, where we see here is the pale stroma, which is called the desmoplastic reaction here. And I'm telling you because it's important towards the diagnosis of this lesion. Whereas the image on the right side shows the small nest of tumor cells, as well as we see some spaces which are lined by these tumor cells. Next slide, please. Now, this is the highest magnification to show the tumor cells and their basaloid morphology. In pathology, basaloid morphology means that most of the cell is composed of this blue nucleus. So these tumor has very blue appearance when we see them at low power of magnification. And we can see here these punched out spaces or cribriform growth pattern. And within these spaces is this pale pink material. And again, we can see a little bit of stroma in between these tumor groups or tumor islands. Next slide, please. And we confirmed the basaloid nature of these tumor cells by performing immunostains. And on the left side, a CK5 immunostain is diffusely expressed by these tumor cells, whereas P63 is positive in the periphery, in the peripheral cells seen on the right side. Next slide, or maybe I think this is the last. This is a very unusual or very rare tumor of the prostate composed entirely of basaloid cells. In prostate, we can see basal cell hyperplasia versus basal cell tumor. And sometimes it's a very challenging differential, but here going by the extent of the growth, altered stroma and cribriform architecture, it's consistent with basal cell carcinoma of prostate.
Thank you, Dr. Verk, very much.
Hey, can we ask some questions of Dr. Verk while we're at it?
Sure.
Or maybe, when you look at this pathologically, help us understand why, if you look at the case reports of the literature, it's whether this is an indolent mass or is this an aggressive tumor, and they're all over the map on in the case reports there, whether it's indolent or aggressive. Is there any way for you to make an assessment about the aggressiveness of this tumor? And then second, why do you see in prostate cancer loss of the basal layer and basal cells, and the more poorly differentiated tumors? So how is this a malignancy and loss of basal cells in the Gleason 7 prostate cancer? I'm confused.
Okay.
How is this a carcinoma?
Right. So first of to answer your first question, what are the aggressive features of prostate basal cell carcinoma, which can predict aggressive behavior? As you said, that it's all over the place in the literature, and I also went over pathology literature. There are not many papers. The largest series was of about 29 patients, and they showed that this cribriform pattern is one of the features that can predict aggressiveness. But again, there are no definite features. Other features that has been shown in literature are perineural invasion, lymphovascular invasion. I didn't see it, but this is the transitional zone of the prostate. There might not be many nerves in this area to show perineural invasion. Another one more histologic feature that can predict aggressive behavior is solid large nest of tumor with central necrosis. Again, that was not present in this case, but as you see that in this case, tumor cells are present at the margin, so I don't know what is left behind in the patient. To answer your second question, why is it cancer? Yes, so there are two types of cancer here, prostate acinar adenocarcinoma and prostate basal cell carcinoma. So in normal prostate epithelium, we have two layers of cells. One is the, it's called acinar cells, and they are facing the lumen, and those are the cells responsible for making prostate secretions. Whereas we have the basal cells, and they are at the outer side of these glandular cells or acinar cells. So when we have uninterrupted proliferation of acinar cells, there is no proliferation of basal cells, and that results in acinar prostate carcinoma. Whereas when we have only basal cell proliferation, it results in basal cell adenocarcinoma.
Gotcha. Thank you.
Does that answer the question?
Yeah, no, thank you. Miad, do you want to move to the, so how would you, not just in conclusion, you would say based on the cribriform pattern, but there's no LBI or perineural invasion. So it's kind of in the middle, right, as far as you're concerned. It's kind of gray zone kind of thing. All right, thank you.
Yeah, sure.
Thank you, Dr. Berg. So we'll have Dr. Shesh, one of our radiologists, just quickly go over imaging as well. If you don't mind, Dr. Shesh, are you there with us?
Yes, I'm here.
Awesome. So Dr. Shesh is one of our assistant professor of radiology, Dr. Terris, and he works very closely with us, especially in our tumor board setting. Here, I'll leave it to you, Dr. Shesh.
Okay, so this was a, these are two images from a prostate MRI, which was performed at an outside hospital in February of 2019, which were made available recently. On the left, we see a T2 axial weighted image. On the right, we see a diffusion weighted image. And what we see is in the center of the image is the transition zone of the prostate. Behind it, you see the two seminal vesicles. There's a Foley catheter going right through the middle. And I want you to look at the left half of the transition zone. Miad, can you, that's the, well, yes, that's the patient left. So look at the patient's right. Mm-hmm. Yep. So that area there, you can see is slightly more bright on T2, that geographic area, and it's bulging a little bit. That's very, very abnormal. And on the corresponding diffusion weighted image on the right, you can see that it's very high signal. So that would be, I don't know how this was read on the outside. This would be called a PIRATS 5 lesion, which would be highly consistent with clinically significant prostate cancer. It is unusual, though, for a prostate cancer to be this T2 bright. Usually they're charcoal dark. So this is a little funky looking. It doesn't look like a typical prostate cancer that we see. Okay, so yeah, go ahead. Okay, so actually this MRI, which was also done at the outside more recently in March, was actually done using a perianal fistula protocol because of the patient's complications. And when we read it initially, actually, it was read as a perianal fistula, but right now, I mean, it looks like a bomb went off in this patient's prostate, really. We don't really see a well-defined prostate gland. The very T2 bright stuff in the back there posteriorly is actually part of the fistula. But if you recall that signal of the tumor on the previous MRI, we now see that all throughout the middle of where the prostate is, especially on the image on the right. You can see it's encasing the catheter there. Go to the other image, Miad, with your mouse. Yep. So you can see there's that kind of intermediate T2 signal, kind of bright, all throughout where the prostate gland should be. And that's all tumor. That's a huge tumor. We don't really understand, what happened in the interim. I mean, there was a simple prostatectomy. We don't know what would have happened had there not been a prostatectomy. It's possible that that surgery kind of messed up the borders of the tumor, and now this is what's there. But certainly just based on this, you can see it looks like significant progression of the tumor.
Thanks, Dr. Shesh.
I just want to ask Hiram a question. He had a gastrographin enema out of interest. He still has his loop ileostomy. He had a gastrographin enema on Friday, and the report is that it looks normal. Do you see a fistula here, or what's more definitive? He has a gastrographin enema that's like normal.
Yeah, I mean, they're complementary studies, really. The gastrographin enema is a fluoroscopic study. It's a dynamic study, so we can inject contrast and view in real time where the contrast is going. Sometimes small fistulas may not opacify with the enema. The MRI has exquisite soft tissue details, so we can see small tracks. So they should be used complementary. I didn't review the images for purposes of the fistula. I'd like to look at them side by side, and then I'd be able to offer you more information on that. But neither one of them is better than the other. They're complementary. So
the tumor looks to you as extra. At the time of surgery, just so everyone knows, I saw the fistula in the middle to distal part of the prostate, and when we went to close the fistula, there was a big nodule that was like I could see through the fistula tract that was at the fistula tract, and he had some voiding dysfunction, so I could see this big nodule the size of a thumbnail or more. So I just excised it while I was there to help me to close the fistula tract. But this nodule that I took out was in the fistula tract. And the capsule of the prostate, at least at the time of surgery, looked very smooth and normal. Essentially, the approach was like a perineal prostatectomy and closed it. And it looked very nice and smooth, and it didn't look extra prosthetic at the time. It's just that this tumor was in the fistula tract. And then we interlaid a gracilis muscle. So there's muscle now between the prostate and the J pouch. So.
And the surgery was what date?
2 or 3 months ago. I think in December or something like that. No, when was it? November. So 6 months ago.
Okay, before this MRI though.
Yeah.
Yeah, he's had pretty extensive surgery down there in the pelvis with his ulcerative colitis, the pouch, and now the gracilis flap. So I think it's going to be very difficult to be certain about that. Like I said at the beginning, his prostate looks horrible in general.
Yeah.
It's hard to say how much of that is from the surgeries, or how much of that is from this tumor. It's on these images, it looks like it's outside the capsule, especially if you look at the right image, the right side of the prostate, the right of the other image.
Yeah.
Yeah, so that right there, right where the mouth, right there, that whole tissue doesn't look encapsulated. It looks like it's abutting the levator on the right there. That's the black line on the right. So that looks like it's outside where the prostate would be. But again, he had a simple prostatectomy. It's very unclear from the image. In fact, the original radiologist who read this, who didn't have the history, didn't even know that the patient had a prostatectomy, didn't know that the patient had a tumor anywhere. It was just, it's such a abnormal appearance of this area in his prostate that it's just very difficult. So with this information, it's going to be more difficult to say whether there's true extraprostatic extension or this is all or there's some post-surgical change and disruption of the fascial planes. It's hard. But from these images, just looking at these images, to me, it looks like there's gross tumor, at least on the right side posteriorly, that's outside the prostate.
Right. Hey, Miyad, we're going to run out of time. Martha, are you still there? Dr. Terris?
Yeah, so
What do you think we should do, and what's the next step, and what should we tell the patient? Should we do biopsy, transrectal biopsy? So what should we tell him? He's a relatively healthy 63-year-old. He's a young 63-year-old. Aside from the ulcerative colitis, he doesn't have really any medical problems.
Yeah, I mean, these, you know better than I do that the one reason that fistulas keep recurring is cancer, right? So I think he needs more complete staging. So I'd get full abdominal imaging and a bone scan. The basaloid can metastasize to the bone. So that would be something just to be sure we know how bad of a disease we're dealing with. I see one case report of it having uptake on FDG PET. So that might be something to get to see what kind of disease we're dealing with. But you know me, I mean, I would say pelvic exents what this guy needs and just 2 stomas. You could do it with without a new bowel anastomosis. So plug the ureters into his existing ileostomy and bring the other end, and then divide the ileum just above that and bring it over to the other side so that his recovery is faster. But this is a pretty bad actor. I think you got to stage him up and then make a decision to do a big surgery. I think his fistulae are never going to stop recurring with that kind of tumor down there.
No, that's very helpful. Let's say he refuses a pelvic exent. He's a nice guy, but he's a little kooky personality, not realistic. He's childlike.
Yeah. Boy, you're really limited. I see people have given docetaxel for basaloid. I don't know that the results have been very good. Certainly want to give pelvic radiation to somebody with ulcerative colitis and a J pouch. And fistulae, that sounds like a disaster waiting to happen. I would talk to your medical oncology people, but I don't think you've got a lot of options there. There have been people that have tried hormone therapy, but it's not really that hormonally responsive, I don't think. I'd have to really do a better literature review on it, such a rare tumor.
Yeah, hi. Thank you so much. And this is Dr. Stein from Medical Oncology.
Right.
You're absolutely right. I mean, hormonal therapy has not really been shown to be particularly useful in this setting. There was one case report of a BRCA-related basaloid, so we will certainly look for that. But for the most part, these are not responsive to chemotherapy either. And we can try to do some other things like single cell sequencing and then RNA profiling, and then try to some fancy algorithms here to maybe see if there's a particular drug that might work for his specific tumor based on some predictive algorithms. But I worry that ultimately won't be curative. Pretty much right. No matter what drug we give him, ultimately resistance is likely to develop. So I think we probably should discuss exenteration, but I don't want to bias the conversation in that direction.
Yeah, I think that's where you're headed ultimately.
What does everyone else vote here? Is any of our oncologists and maybe Chuck, if you're still on the line, what do you vote for, Dr. Drake?
Did we lose him?
We lost his interest. Ah, all right. He's kind of ADD anyway, so we lost his interest. All right, is Chris Anderson? I saw you meant a comment. What do you think, Chris?
Yeah, hey, I'm here.
What do you think we should do? What's the answer?
Just out of curiosity, what makes you lean towards exent as opposed to prostatectomy? Is there a reason that you would have to take this guy's bladder out, other than, he would likely be incontinent, but.
Well, that and the fact that he's got all these fistulae, I think that he's just set up to develop an even worse fistula after prostatectomy. because you've got an anastomosis there on top of a very diseased colon. And I'm not convinced from this MRI that this tumor isn't actually invading into the wall of that rectum a little bit. That may be all just inflammatory reaction from the prior fistula repair, but it would be very difficult getting the prostate off of that rectum.
Yeah. Yeah. Well, Dr. Terris, thank you. I mean, in for just respect of everyone's time, and because we have an 8 o'clock speaker, I'd like to just thank you so much for joining us for this Empire series. Thank you all for contributing, and it was amazing discussion across disciplines. So I think we're really fortunate to hopefully be able to continue this kind of platform and this virtual visiting professor type experience to until we can actually invite you back. But Dr. Terris, thank you again, and thank you everyone, Dr. Burke, Dr. Shaish, Dr. Brandis, for being a part of this. If anyone,
Thank you, Martha. Thank you.
Thank you. Appreciate the invitation. Y'all be
Thank you.
careful.
Next time we'll do it in person.
Great.